and hard for me to keep it to 15 or 20 minutes, but I'll do the best that I can. I have no conflict of interest at all. I wanted to share some of the objectives with you that I hope to get to, and I sort of give you a little bit of food for thought, no pun intended. But I wanted to sort of describe malnutrition because it is ever present among our patients, sort of describe the goals of nutrition therapy briefly and the benefits of intervention. Look at what we refer to as nutrition impact symptoms, or symptoms that impact the patient's ability to eat, maintain weight, and sort of also go a little bit into the other spectrum of obesity, risk of recurrence, survivorship, and also talk lastly about the role of the care team, including involvement of a fitness professional and caregiver. Malnutrition really has evolved quite a bit, and more interest now amongst our patients, especially in cancer centers, obviously, is to screen for risk, and I'll talk a little bit more about that, but that's a very important matter that you'll hear more about. A lot of cancer centers do not screen for malnutrition risk, unfortunately, but that voice is getting much louder. So I'm sort of painting a grim picture for you, but it's a place to start, and hopefully we'll get a little bit more hopeful as we complete the slide set. But patients with higher risk for malnutrition are, your head and neck patients, GI cancer, patients including pancreatic, lung, as well as patients with more advanced disease states. It's often related to the ultimate cause of mortality, unfortunately, in some patients, malnutrition is. And even attempts to reverse severe depletion in some of our patients are generally unsuccessful. So we do not like to wait for our patients to get to that point. We like to be proactive and to see these patients sooner than later. The majority of cancer patients who experience weight loss as their disease progresses, this can be really a major prognostic indicator of worse survival and impaired response to treatment. So something that to keep in mind is the goals of nutrition intervention is to keep our patients on treatment. Of course, if patients are losing weight and feeling unwell and not eating, it's certainly going to impact their treatment. Then there are dose reductions, treatment delays, but it's really all about how do we give our patients the best chance to receive the prescribed treatment by keeping them nutritionally well throughout treatment. And it's a team effort. We should all be thinking about nutrition in the management of our patients. The goal is symptom management, and it's really to address every new barrier as it appears during the treatment cycle. And how do we address this? By validated screening tools to assess for malnutrition risk and application of evidence-based medical nutrition therapies. So early screening, I can't say it enough, is really imperative in these patients. Understand their nutrition risk, understand what's compromising their ability to eat. And this helps to identify patients at risk early before their nutritional decline. Caregivers, I was asked to talk about the role of the caregiver. It really is wonderful when I see a patient and they bring a caregiver with them at the first treatment or the first meeting, and I can't tell you how much I rely on that care provider in providing additional information about how the patient is eating or what may be compromising that patient's ability to eat at home. So the benefits of maintaining good nutritional status during cancer treatment. So I'm probably preaching to the choir here, but there's a better response to treatment, improved recovery, reduced dose reductions, and chemotherapy or any other treatment. And this is usually what I talk with my patients on the first visit. And then this really buys them into trying to maintain their nutritional status throughout treatment. Just this morning, I had a great discussion with some of our GI surgeons who I'm hoping to work more with in terms of seeing patients preoperatively to optimize nutrition before surgery. So this is primarily in our GI cancer patients who are undergoing colorectal surgeries, gastrectomies, pancreatectomies. We know that if these patients are well nourished going into these kinds of surgeries, that they are going to certainly have decreased morbidity, decreased mortality, decreased readmission rates, decreased length of stay in the hospital, and ultimately reduced hospital costs. So I bring this slide to light because I think there's a real need among providers who see cancer patients to use standardized language around identifying malnutrition. Part of that is understanding how much they're eating and if they are eating enough, depending on how many days they're eating enough or not eating enough. Their unintentional weight loss and to what degree they are experiencing that weight loss in the time span. That will, of course, determine the severity. And then there are other, what we refer to as a nutrition-focused physical exam, which assesses for loss of subcutaneous fat. You can see there where we're assessing, under the eyes, the orbitals, the rib cage, triceps, or assessing and assessing for loss of muscle mass, looking at grip strength, muscles in the chest, shoulder, back, thighs, calves. And this was a pretty important paper, came out in 2012 about, certainly not a validated tool for diagnosing malnutrition, but it's a basis of which we can start to diagnose malnutrition in cancer patients. All it would take would just be the presence of two of the following characteristics: decreased oral intake, and that's talking with our patients about their preferences, their aversions for foods, their GI intolerances, any barriers to eating, treatment regimens and toleration, functional status, fat loss, like we talked about in the previous screen, or muscle wasting, fluid accumulation, if they have edema present or not. This is a very, of course, like I had said, malnutrition is really evolving. Diagnosing and assessing for among cancer patients is becoming much more prominent in our cancer centers. So I feel like this will continue to evolve even more so that we can come forward with more validated tools for assessing for malnutrition. I wanted just to show you, because some of this is about, the physical functioning of our patients and the impact of perhaps physical activity for our patients, but measuring hand grip strength is a very easy thing to do in the clinic. We have a hand dynamometer in our clinic that we can do serial measures at baseline throughout treatment. Like I said, it's also another one of those characteristics that we use in looking at malnutrition. This really speaks to, I was asked to talk a little bit about some of the symptom management that we do. So a lot of what we do in the clinic and throughout treatment when we're following our patients, that we're assessing for a lot of these nutrition impact symptoms, because they can have significant impact, of course, on their ability to eat. as well as on their weight. I mean, you can only imagine what our patients are going through. Some of them that are seeing multimodality treatments. For instance, our pancreatic cancer patients who start with chemotherapy, then on to chemoradiation, then to possibly surgery, and then to possibly more adjuvant therapy, though that's changing. But they come almost full circle 10, 12 months of treatment. So they can experience any one of these symptoms that can impact their ability to eat. And I really wanted to speak to the impact of weight loss on muscle loss. It has a dramatic effect on our cancer patients. The loss of muscle tissue really helps us to understand some of the side effects that cancer patients may experience. And I've listed here, when you see a decline in skeletal muscle, all of those things that come with that, increasing risk for fatigue. You know, they don't want to help themselves in the kitchen to even prepare foods for themselves. They can't even think about what they want to eat. Then they're going for foods that may be more simple to prepare or relying on caregivers. And as a patient experiences this involuntary weight loss, they're having lack of energy for daily activities, reduced ability to move with balance and safety. Even something that probably isn't considered very often is the impact on smooth muscle. If there's a loss in lean body mass or skeletal muscle, smooth muscle is often compromised, where you'll see delayed gastric emptying, where patients feel full very quickly. They feel full even before they begin to eat, or delay in intestinal transit, constipation, slow bowels. So I'm sure you can understand how that certainly can impact their ability to eat. I want to speak to this slide because, you know, I think many of us think of malnutrition as the very thin, cachectic person. But on the other end of that, my worry is that there is this sarcopenia that can be observed. And sarcopenia is severe muscle depletion. And it's observed in patients with a wide range of weights and body compositions. So like I had said earlier in those slides about looking at a physical assessment for weight loss, you'd think, well, if you saw someone who's obese, how can you assess clearly for a loss in skeletal mass or subcutaneous fat? It's hard, but it can be such that this particular group of patients that experience sarcopenia, to include sarcopenic obesity, where they're losing severe muscle loss, they can have very poor outcomes on treatment. And even so, that obese patients, cancer patients who are losing weight, often can have the shortest survival times and the worst outcomes. I've had patients in that case where I'm very worried about them, and the same message is when I'm sitting down to meet a new patient and they're overweight and or obese and they're about to start treatment. A lot of my, you know, the goal for those patients is to maintain their weight during treatment to avoid severe weight loss for this very reason. So I take it very seriously when a patient who is obese has lost severe weight, particularly if they're also older. So we know that just as a matter of aging, that as we get older, we lose lean body mass, and so that person who's 70 or 80 years old and has lost about a third of their muscle mass, then you throw in cancer and something like sarcopenia, you really worry about these patients getting through treatment. Unfortunately, I think not all providers look at it that way, or even patients themselves may say to you, oh, well, I needed to lose weight anyway. it's certainly something that we need to take seriously. And I only point this out because you'll hear more about it if you've not already heard about it. But in terms of assessing for sarcopenia, if we failed in the physical exam and looking at loss of skeletal muscle mass or subcutaneous fat, CT imaging was of the first to really identify sarcopenic muscle loss, and that's simply looking at the vertebrae. Actually, it's L3 and L4, where they can look at CT imaging and really assess for sarcopenia. And other kind of cool measures in the clinic that have been used in research, we're hoping to bring into the clinical setting to assess for skeletal muscle loss. And those would be things like using a bioelectric impedance and ultrasound. So just something I wanted to tell you about, thought was pretty interesting. Other considerations. So I wanted to talk about other considerations such as obesity, some of the late effects that we might see in our survivors, and as well as the comorbidities that some of our patients may have that may have some impact. So the strongest nutritional factor related to cancer diagnosis and survival is obesity. Of course, it's associated with increased mortality from some of the cancers I've listed here. And when I first started as a dietitian here at the Cancer Center, I was very interested in weight gain, the weight gain that some of our breast cancer patients were really suffering from, was really difficult for them. And we know that those patients in particular, if they're diagnosed and they are overweight or obese at diagnosis, this certainly increases or can increase their risk for recurrence. Just a snapshot to look at survivorship, because it's really, when we follow patients here at the Cancer Center as dietitians, we follow them through this continuum of care from diagnosis through treatment, and then hopefully and through survivorship. But there certainly can be some difficult treatment-related nutritional problems that really never go away. I think about our head and neck patients where treatment, continues to have very lasting effects on these patients. In head and neck patients, they can have G-tubes for years after treatment if they're just having dysphagia or if there's strictures that are developing. And their eating experience is very different and can be very dissatisfying to them. Bone health and prostate, breast cancer. Patients with gastric cancer or have had pancreatic cancer and have had pancreatectomies, they certainly can have bone health issues. The number of dietary supplements that our cancer survivors on, it's astounding, whether it's during treatment or in survivorship, and answering their questions and educating them about what they're taking, so that they can make decisions on whether they take these things or not. And I threw this slide in because I think we can't ignore this, that our patients, they come with comorbidities. This is a little grim, and I apologize for that, but I think it's something that we have to think about. Greater than 80% of our older adults have at least one comorbid condition at the time of their cancer diagnosis, and then collectively can contribute to poor long-term survivor. I just met a patient, unfortunately, was on the kidney transplant list. He's stage 5 kidney disease, and then diagnosed with an ampullary cancer, and unfortunately went on to have a Whipple resection. So discussing nutrition with him can be pretty complex when I have to think about kidney health and someone who's, 120 pounds as a male, struggling to recover from a Whipple resection. There's hope, though. There are some great nutrition intervention studies looking in survivorship. A lot of these studies are looking at breast cancer and lifestyle, of course, showing that weight loss is feasible in this and safe in this population. I have to tell you a funny story. When I first started working here at the Cancer Center, we think about that like, oh, cancer, everybody needs calories, but in some cases, not everybody does. We have patients that are doing well tolerating treatment, and it might not be the same diet you hand to the person who's severely losing weight. But I had one of the surgeons ask me to see one of the breast cancer patients, and I went about seeing this patient and looked at just healthy eating, thinking, well, they're on treatment, and until I was corrected, and the surgeon had said, this person needs to lose weight, and that really never came to my mind. I've certainly learned a lot in the last 20 years. So sort of to tie this up, I was asked to sort of share, well, how do I see fitness, moving, physical activity as part of the nutritional care of a patient, and I very much see it. I can't talk to a patient about improving their nutrition, whether they're on treatment or not, without also talking about whether they're moving or active. Assessing for that anytime I see a patient, because of course what's becoming, or probably has been around for a while, is protocols that are looking at getting cancer patients ready for surgery, known as ERAS programs. And they started out with colorectal patients in terms of patients ready physically, as well as nutritionally prior to surgery. But I know there's some really good studies looking at patients who are on treatment and introducing physical activity and how that makes a huge impact for these patients. In fact, a colleague of mine at MD Anderson in Texas, this was a study, and I don't know what's happening to it now, but they're actually getting their patients moving. These are pancreatic cancer patients undergoing treatment before surgery. So they're getting these patients moving in some capacity throughout their treatment length, and they're looking at the impact on their surgical outcomes. Does physical activity increase the ability for chemotherapy to get to a tumor that may be less vascularized because of the physical activity piece? So I know our surgeons here in thoracic, Dr. Finley is a very pro physical activity for patients who are undergoing treatment prior to having an esophagectomy. So I think the fitness part of keeping our patients fit is extremely important. I've thrown on a few resources, and these are resources that maybe, hopefully, you don't know about. I usually put some of the same resources on my slides for other presentations, like the American Institute of Cancer Research, AICR.org, which I didn't list up here, which is an excellent resource for patients and providers, as well as a couple of others here, the Eat to Beat Cancer and Cook for Your Life. And at that, I thank you so much. I think you all were pretty attentive. I didn't know, I didn't scan the pictures.
Thank you, Janine.